For part 2, we follow the same structure we used for continent.
Let's begin with the definition of constipation. Constipation is a syndrome characterized by difficult, infrequent, or incomplete defecation. Patients may report difficulty stool passes, hard or lumpy stools, a sensation of incomplete evacuation, reduced stool frequency, or an inability to evacuate stool completely. The Brittle Stool Form Scale classifies stool consistency from Type 1 to Type 7. Type 1 and Type 2 are hard, lumpy stool and suggest constipation. Meanwhile, Type 3 and Type 4 are considered normal, and Type 5 to 7 represent progressively looser stools. The stool form provides a simple way to assess colonic transit and is an important part of the Rumford criteria. What is the Rumford criteria? To make a formal diagnosis of functional constipation, we use the Rumford criteria. The diagnosis requires at least 2 of the listed symptoms occurring in more than 25% of defecations. These symptoms include straining, hard or lumpy stools, typically Bristol stool type 1 or 2, a sensation of incomplete evacuation, a feeling of anorectal blockage, the need for manual maneuvers to facilitate defecation, or fewer than 3 spontaneous bowel movements per week. One important point is that bowel frequency alone does not define constipation. A patient may have a bowel movement every day but still meet the Rumford criteria if they strain, pass hard stools, or feel incompletely empty. In addition, loose stool should rarely occur without the use of laxatives, and the patient should not meet the diagnosis criteria for irritable bowel syndrome. Finally, remember that Rumford defines a chronic condition. The symptoms must be present for the last 3 months, with symptom onset at least 6 months before the diagnosis. I think everyone used to experience constipation. So let's imagine together. It's just like UI, constipation has a significant impact on other people. It is associated with abdominal discomfort, reduced quality of life, mood changes, depression, irritable, and they might increase to-do activities. In patients with dementia, they may present as agitation or behavioral changes because they are unable to communicate their discomfort. Similarly, constipation has increased healthcare utilization and economic costs, making it an important public health issue. Importantly, constipation can lead to serious complications. Common complications include fecal impaction with overflow incontinence, and it can cause urinary incontinence as well, because a distended rectum can compress the bladder or urethra. Other complications include rectal prolapse, anal fissure, hemorrhoid, and in severe cases, constipation may progress to sigmoid volus obstruction, stercoral perforation, which is a severe medical condition where harder stool breaks the wall of the large intestine. It causes severe infection and requires emergency surgery. Before discussing constipation, let's review the normal physiology of defecation. Starting with colonic propulsion, this phase is the phase of propelling content to the rectum. The movement depends on the bowel contraction, and the bowel contraction are particularly active after waking in the morning and after meals because of the gastrocolic reflex. When the contents move to the rectum, is then the phase of rectal filling. When stool enters and distends the rectum, stress receptors are activated. This triggers the rectoanal inhibitory reflex, causing the relaxation of the internal anal sphincter. After that, the pre-expulsion phase. Although the internal anal sphincter has relaxed, but we decide not to defecate yet. So, the external anal sphincter and the puborectalis muscle remain voluntarily contracted, so we can maintain continence. After that, the expulsion phase, when we decide to defecate, the external anal sphincter and the puborectalis muscle voluntarily relax, while the Valsalva manual increases intra-abdominal pressure. At the same time, the anorectal angle strengthens, allowing stool to pass. Finally, the recovery phase. After the rectum has emptied, the external anal sphincter and the puborectalis muscle contract again, restoring continence until the next rectal filling cycle. The neural control of defecation is very similar to that of micturition. Both depend on coordinated autonomic reflexes together with voluntary control from the brain, allowing us to maintain continence until an appropriate time and place. The parasympathetic nervous system, carried by the pelvic nerve, promotes defecation by stimulating colonic and rectal motility and relaxing the internal anal sphincter through the rectoanal inhibitory reflex. In contrast, for the pudendal nerve, which is a somatic nerve, provide voluntary control of the external anal sphincter and the puborectalis muscles, so we can maintain continence until defecation is initiated voluntarily. Finally, the cerebral cortex provides conscious awareness and voluntary control, similar to micturition. So it's allowing us to decide when and where to defecate. Therefore, normal defecation requires coordinated function of the autonomic nervous system, the somatic nervous system, and the brain. These orders affecting any part of this pathway, whether the peripheral nerve, spinal cord, or central nervous system, can impair normal defecation and contribute to constipation or fecal incontinence. The gastrointestinal tract also undergoes age-related physiological changes. Again, I like to emphasize that constipation is not a normal consequence of aging, but aging reduces gastrointestinal functional reserve. making other people more susceptible to constipation. Just for example, when they exposed to comorbidities, medication, inadequate fiber, and fluid intake. So let's see what changes when we get older. Starting from colon. In the colon, aging is associated with reduced enteric neuronal function and increased collagen deposition, all together leading to slower colonic transition and reduced bowel motility, which increase the risk of constipation. Next, the rectum. The rectum also reduces motility and increase the risk of fecal impaction. At the anorectal level, it reduces internal anal sphincter tone together with weaker external anal sphincter tone and pelvic floor muscle. Taken together, it decreases continence, increasing the risk of fecal urgency and fecal incontinence. Next, let's look at the causes of constipation. When approaching constipation, it's useful to classify the causes into primary and secondary constipation. Primary constipation is functional intrinsic dysfunction of the colon or anorectal region. We should diagnose primary cause or suspect after secondary causes have been excluded. So let's see for example of primary causes. There are slow transit constipation, which results from reduced colonic motility. The second one is dyssynergic defecation, in which the pelvic floor muscles and anal sphincters fail to coordinate. The third one is irritable bowel syndrome with constipation predominant, or IBS-C, which is characterized by abdominal pain and altered bowel habits. However, in older people, our priority is always look for secondary causes first, because many of them are reversible. The first diagnosis that should always be considered is colorectal malignancy, particularly in patients with alarm symptoms. The next one of the secondary causes is medications. So a careful medication review is essential. Other important causes are endocrine disorder such as diabetic mellitus, hyperthyroidism, hypercalcemia, neurologic disorder such as Parkinson's disease, diabetic autonomic neuropathy, nutrition, for instance, low fluid and fiber intake, rheumatological disorder like systemic sclerosis or other connective tissue disorders, psychological disorder, anatomic dysfunction such as strictures, post-surgical abnormalities, anal fissure, fistula, rectal prolapse. And the last one, don't forget reduce mobility and a sedentary lifestyle, because physical inactivity can slow colonic transit and is one of the most common contributing factors to constipation in older people. One important concept in geriatrics is that constipation is often multifactorial. Rather than searching for a single cause, we should identify on contributing and potentially reversible factors. So, before labeling a patient as having primary constipation, always exclude secondary causes first. One of the common causes of constipation is medications. Several prescribed medications can cause constipation through different mechanisms. For example, opioid. It activates mu-opioid receptor in the gastrointestinal tract, so it reduces intestinal motility and secretion. Anticholinergic property, it inhibits parasympathetic activity, so it reduces motility and slow bowel transit. For calcium supplement, it slow colonic transit and it increase stool firmness, so it makes stool harder to pass. And NSAID, it inhibits cyclooxygenase, resulting in reduced prostaglandin synthesis. Then this decreases intestinal secretion and motility. Okay. That's why don't forget to careful medication review. Just as we did with UI, we must screen for alarm symptoms. The purpose of this alarm symptom is to identify patients who may have colorectal cancer or another serious underlying disease. Alarm features include hematochezia, positive fecal occult blood test, obstructive bowel symptoms, acute onset of severe constipation, constipation that persists despite appropriate treatment, significant unintentional weight loss, a change in stool caliber, or in other words, is pencil thin stools, a family history of colorectal cancer or inflammatory bowel disease, and recent change in bowel habit. If any of these alarm features are present, don't simply prescribe a laxative. The patient requires further evaluation, often including colonoscopy to exclude colorectal cancer. For clinical assessment, absolutely, we should start with history taking. You can follow the diagram, the flowchart of Thai guideline. Begin with confirm the diagnosis of constipation. Apply the Rome 4 criteria. Use the Bristol Stool Form Scale to assess stool consistency and determine whether the patient's symptoms are consistent with constipation. Next, characterize the bowel habits. Ask about stool frequency, consistency, straining, incomplete evacuation, prolonged time spent on the toilet, or the need for manual maneuver. These symptoms help distinguish different constipation subtypes. Next, follow the flowchart. You can see that. Don't forget to rule out secondary causes. You should actively look for secondary causes by review patients' medical history, medication, nutrition, fiber, fluid intake, physical activity, and other comorbidities or other secondary causes. Because many causes of constipation in older people are potentially reversible. Again, the next one, don't forget to screen for alarm features. The purpose is to exclude other serious organic diseases, especially colorectal cancer. Next, assess about the complications. Because the complication may significantly worsen outcomes. The complications of constipation such as fecal incontinence, urinary incontinence, urinary retention, and delirium. Finally, perform a comprehensive geriatric assessment helps you evaluate overall health, including functional status, mobility, cognition, nutrition, mood, environment barriers, quality of life, patient's goal, and caregiver burden. This comprehensive helps identify modifiable contributing factors and guide you create an individualized management plan. You notice that this approach closely mirrors the assessment of UI. Because in geriatric medicine, we don't focus solely on bowel symptoms. We assess the whole person to identify reversible factors and optimize function and quality of life. The physical examination should be guided by the clinical history or any suspected underlying causes rather than performed routinely in every patient. Abdominal examination can help you to diagnose it for some pathologies such as fecal impaction, bowel obstruction, or other structural pathology. And digital rectal examination is quite important to assess for retained stool, mass, anal fissure, tone of sphincter, the size of prostate in men, and the mass like rectocele in women. And if the DRE show retained stool but the external sphincter is tight, maybe suggest of dyssynergia because the muscle is not coordinated properly. For neurological examination at the anus can assess for the perianal sensation and reflect. And moreover, if you suspect that patient has constipation from neurological diseases or some neurodegenerative disease, you should perform neurological examination that involve align with the cognitive or function or mobility that can guide you to diagnosis. After gathering the information from the clinical history and physical examination, then we think about sending investigation. We send investigation for confirmed diagnosis or rule out some serious conditions. For basic lab, we might consider about CBC to evaluate anemia, thyroid function test, blood glucose, electrolyte, or serum calcium. If we suspect of some reversible cause such as hypothyroidism, diabetes, or metabolic abnormalities. For plain film, it's not routinely required. It's useful when we want to confirm the diagnosis of fecal impaction, the clinical structured bowel obstruction, or acute abdominal pain, and we need imaging to guide us for diagnosis. For colonoscopy, should be performed when alarm features are present or colorectal cancer is suspected. Look at the guideline in your right side. After we confirm diagnosis of chronic constipation, define the cause by exclude secondary causes, colonoscopy if positive alarm features. Then we give the patient the initial treatment. After we treatment patient for a while, but patient is not respond to the treatment. So maybe consider diagnosis of refractory constipation. And if the clinical suggests of primary causes of constipation, you should refer to a specialist for further investigation. The investigation might be include a colonic transit study to confirm diagnosis of slow transit constipation. For example, like in the picture, we give the patient the radial plaque and then follow up for plain film within 3 to 5 days. If there is the retention of markers throughout the colon, suggests that patients have delayed colonic transits. And if dyssynergic defecation is suspected, anorectal manometry may be considered to investigation because it can evaluate the coordination between the rectum, anal sphincter, and pelvic floor muscles during simulated defecation. Now let's put everything together into a practical treatment algorithm following the Thai clinical practice guideline. After we confirm that patients have chronic constipation, and then we find causes of chronic constipation, exclude secondary causes. If patients have alarm symptoms, we refer for colonoscopy. And then we give a patient management. Lifestyle modification is recommended for every patient. After that, laxative agent may be considered. The choice of laxative depends on symptom severity. For patients with mild or intermittent symptoms, use conventional laxative on an as-needed basis. For patients with moderate to severe symptoms, might start regular treatment with conventional laxative. If the patient responds, continue treatment and gradually titrate to the lowest effective dose. But if there is no response, don't immediately switch medication. We should reassess the patient by confirm adherence, review lifestyle measures again, optimize the dose of the current laxative, and reconsider whether an underlying secondary cause has been missed. If constipation remains refractory despite optimal treatment, at this stage, there are two important questions. First, does the patient have clinical features suggesting a defecatory disorder? For example, if the patient has excessive straining, prolonged defecation, a sensation of incomplete evacuation, or the need for manual maneuvers. If the answer is yes, should consider for referring the patient to investigation with specialists. On the other hand, if there is no clinical suggestion of primary causes, maybe consider a newer pharmacological again. If the patient responds, again, try it to the lowest effective dose. But if there is no response, should consider to refer specialists. Let's look into the detail of lifestyle modification. The easiest way to remember is 4F: fluid, fiber, fitness, feedback, and brow training. Let's start with fluid. Fluid intake should be adequate around 1.5 to 2 liters a day. Fiber should be adequate around 20 to 35 grams per day. Regular physical activity supports bowel motility and overall function. The brow training can be very helpful. Patients should be encouraged to recognize and respond to the gastrocolic reflex, especially after meals, and to establish a regular toileting routine at a consistent time each day. Don't forget toileting posture, encouraging patients to use a small footstool and lean forward. It can strengthen the anorectal angle by relaxing the puborectalis muscle here, making defecation easier. For patients with dyssynergic defecation, biofeedback therapy is the treatment of choice. During the session, a small pressure or EMG probe is placed in the anal canal or rectum, and it allows the patient to receive real-time visual or auditory feedback. So patients can learn how to increase abdominal pressure, coordinate with rectal propulsion, and anal relaxation. When lifestyle modification and behavioral interventions are not sufficient, pharmacological therapy should be considered. The first is bulk-forming laxative, such as psyllium. These absorb water, increase stool bulk, and soften the stool. They should be used only if the patient has adequate fluid intake and does not have fecal impaction. Avoid bulk-forming agent in patients with bowel obstruction and fecal impaction because they may worsen obstruction. The second is osmotic laxative, including polyethylene glycol and lactulose. This increases stool water content and softens stool. According to the Thai guideline, polyethylene glycol is the preferred first-line pharmacological treatment. There is milk of magnesia in this group too, but avoid magnesium-containing laxative in patients with chronic kidney disease because magnesium can accumulate and cause hypermagnesemia. The third is stimulant laxatives such as senna and bisacodyl. These stimulate colonic peristalsis and are generally used as add-on or rescue therapy. Although they can use
in the long term, but used when clinically indicated. Finally, the 5-HT4 receptor agonist. There is prucalopride in this group. This drug may be considered in refractory constipation after conventional laxatives have failed. Dose adjustment is required in severe renal impairment, and it is generally avoided when the GFR is below 30. Before we finish, let's summarize the key messages on constipation. First, again, similar to UI, constipation is common, but it is not a normal consequence of aging. But aging reduces gastrointestinal physiological reserve, making older adults more susceptible to constipation. Second, always screen for alarm features and exclude colorectal cancer or other serious organic diseases when indicated. Third, always look for secondary causes before labeling constipation as primary. Pay particular attention to medication, comorbidities, dehydration, inadequate dietary fiber, and reduced mobility, as many of these are potentially reversible. Fourth, a comprehensive genetic assessment is essential because it can evaluate functional status, mobility, cognition, nutrition, medication, environment factors, social support, and the patient scope of care. Because constipation in older adults is usually multifactorial. Finally, management should follow a stepwise guideline-based approach. Start with lifestyle modification and behavioral interventions. Optimize conventional laxatives when needed, and reassess adherence and the diagnosis if symptoms persist. For refractory constipation, consider referral for specialized evaluation and physiological testing when clinically indicated. Okay, today's lecture is both UI and constipation. These conditions are very common genetic syndrome. Neither is a normal consequence of aging. Both are often multifactorial, and both require a comprehensive, patient-centered approach that focuses on identifying reversible causes, preserving function, and improving quality of life. Thank you.